Transthoracic echocardiography, we all know, is a part of cardiac ultrasound, and that is now point of care transthoracic echocardiography that is becoming very popular in critical care medicine because of its rapid availability. It is non-invasive, dynamic assessment of the cardiac function and all. So it has several benefits which we can use in critical care medicine bedside, and few of them are like assessment of the cardiac function, which where we can see left ventricular function, right ventricular function, volume status and fluid responsiveness if we are using as continuous monitoring. Like if IVC diameter we are measuring after each fluid therapy, then we can see the changes in the IVC, and we a sort of non-invasive method for rough guidance of the fluid management in hypotensive patients. Second, we can use it for left ventricular end diastolic area as a tool for estimating the preload. Then hemodynamic monitoring, cardiac output monitoring, that we will discuss more in detail in the workshop session. So that this is a non-invasive method where we can actually see monitor the cardiac output. Valve function, we can assess any valvular stenosis or regurgitation that is the cause for any hemodynamic instability. Diagnosing the acute conditions like pericardial effusion causing cardiac tamponade or pulmonary embolism as a cause for the hypotension that might need immediate management. And of course, last but not the least, guidance of the interventions like central line placement, temporary pacemaker placement, and pericardiocentesis, where immediate action can improve patients outcome. And good thing is that all this can be done bedside only. So what is the benefit of this? It is immediate availability, non-invasive, repeatability. We can bedside on the point, we can do the intervention and see the effect immediately. Portability, and obviously training and skill development of the medical personals. So there are a few limitations, of course. Limitations and challenges are, it is operator dependence. Of course, if it needs training, it has a learning curve and limited views of the 2D echocardiography. So now coming with how we are going to start the transthoracic echocardiography. So first and foremost is the machine. So machine preparation, first is which probe we are going to use. So we should use transducer, that is phased array transducer, cardiac presetting on that, and we need to make sure that the indicator is coming on the right side of the ultrasound screen. So this is the cardiac anatomy, we all are aware about this. So coming to the views of the cardiac ultrasound, first view is the parasternal long axis view. So that is usually the first view, and that gives us the rough estimation of the ejection fraction of the left and the right ventricular both. So how we are going to see the parasternal long axis view. This is how we will keep the probe. So you will see the pointer is directing towards the right shoulder. Probe is kept in the left sternal border at the third to fourth intercostal space with a pointer towards the right shoulder. And what image we will see? Like this. So here we see the left ventricle, right ventricle, interventricular septum, aorta, left atrium, mitral valve, and aortic valve. And here we can see the descending aorta also. So apex is most of the time it is not very clearly visible. So we get a rough estimate of the LV function, RV, and there is aortic opening and the mitral opening. So this is the how we will see. This is the descending aorta, left atrium, left ventricle, right ventricle, and aortic valve here. And this is the shiny structure is the pericardium. So apart from this function, left and right ventricular function, we can see if there is any fluid in the pericardium. Descending thoracic aorta is the to guide us whether the fluid is pericardial or the pleural. If there is any pericardial fluid, it will come above the descending aorta and below this pericardium. If there is pleural effusion, this will come posterior to the descending aorta. So this is how we can avoid any confusion if we are getting any fluid. So second is parasternal short axis view. So keeping a probe in this left sternal border in the third to fourth intercostal space, we will turn our probe pointer from the 90-degree clockwise, so that now it will face to the left shoulder. And here we will get 3 levels. That is a mid-papillary level, mitral valve level, that is a fish mouth view, and the aortic valve level, that is a Mercedes-Benz sign. So this is the pictorial diagram. This is the mid-papillary, where papillary muscles are more visible. This is the fish mouth mitral valve, and this is the aortic valve, making the Mercedes-Benz view. And this is how we are getting it in the papillary view. So once we are turning it on the left side clockwise 90-degree, we will get first the mid-papillary level, which will give a good view for the overall ejection fraction of the right ventricle, left ventricle, and any motion abnormalities are present or not. So second is this fish mouth level. So we will see the mitral valve and how we will get this view. So from the mid papillary level, just slide the transducer little towards the sternum, towards the base of the heart. So we will get the mitral valve more in position. So anterior, we are seeing the anterior and posterior leaflet of the mitral valve in this position. The third is the aortic valve level, that is the Mercedes-Benz view, and it allows again to visualize the right ventricle, the right atrium, this is the tricuspid valve, this is the RV, right ventricular outflow, and LA is also visible along with the aortic valve, which is making the Mercedes-Benz sign. So how we are going to get this view? We need to tilt the tail of the probe inferiorly, pointing towards the aortic valve from the previous level. So slight 5 to 10 degree max to max movement will give you this view. Third is the apical view, and that is the most important views that to obtain for the hemodynamic assessment of the heart. So it has again different views at different level. First is apical 4-chamber view. So from the parasternal short axis view, we need to slide the transducer towards the apex of the heart and keeping the pointer towards the left side at around 3 o'clock position. So once we reach the apex of the heart, then we will see the left ventricle, and we need to tilt the tail of the probe slightly towards the patient's foot. So this is how we will keep the probe pointing towards at around 2 to 3 o'clock position at the apical region, and we see this diagram. So this is right atrium, right ventricle, left atrium, left ventricle, interventricular septum, apex is visible, mitral valve, tricuspid valve. So for the good assessment, this image should be straight. At times we might get tilted image. So try to tilt your probe little bit so that we get this straight image. So this is the video of the apical 4-chamber view. If at times we might get in obese patients, we might get problem in obtaining this view. So what maneuver we can do is just tilt the patient slightly towards the left in the left lateral decubitus position, and again try to focus on the left apical 4-chamber. So next is the apical 5-chamber. Actually, the 5th chamber is not exactly any cardiac chamber. It is the aortic valve and the left ventricular outflow tract. So this view is very important when we are calculating the cardiac output of the left heart. So from the apical 4-chamber, slightly tilt the tail of the probe towards patient feet so that the probe is opening towards the head and side. And we get slightly 5 to 10 degree tilt, we will get this apical 5-chamber view. So this is the 5-chamber view. Here we are seeing the left ventricular outflow tract aortic opening. So this, how we are going to monitor the cardiac output, we will better see on in the workshop station how to calculate the cardiac output. Next is apical two-chamber view. So here we need to tilt the probe so that the pointer is almost at the 12 o'clock position in the apical region, and we will see this. So it is apex, inferior wall, anterior wall, left ventricle and left atrium and the mitral valve. So we are focusing on the left chamber on the left side of the heart, and it is a very good view to assess the inferior wall, anterior wall and the apex of the left ventricle and also mitral valve assessment. Next is coronary sinus view. So this is not very commonly used in ICU point of view, but at times we might get this view and we might think there can be atrial septal defect. This can be misinterpreted as atrial septal defect because if we are focusing on apical fourth chamber, but if the tail of the transducer is tilted too much towards the patient's head, then we might get this view and it will look like this. So this is the right ventricle, left ventricle. This is our right atrium and this is a coronary sinus. So don't get fooled thinking that this is any septal defect. Then next, fourth view is the subxiphoid or subcostal view. So this will again giving the structures more or less same as apical four chamber view, but approached at a different angle. So this is when mostly we are using it when we are not getting very good view in the apical four chamber, not possible to tilt the patient, or in patients where there is poor acoustic windows like in COPD or emphysematous patients, or in trauma patient as a part of EFAST scan. So this is how we keep the probe in the subcostal area. Again, the probe is pointer is towards patient's left, and here we go almost parallel to patient's skin. So our probe holding position is also different. Here we need to dig it in the patient's subxiphoid region. So we need to hold the probe like this and open the cardiac image. So this is the image we are going to get. This is the right ventricle, left ventricle, mitral valve, right atrium, tricuspid, left atrium. And this is the septum. So it gives a very nice idea about the all chambers of the heart. Along with there, we will see the IVC and the liver. This is the liver. So always keep this liver in the center while seeing this position. So this is liver, this is pericardium, right ventricle, right atrium, left ventricle, left atrium. So obviously if there is any pericardial effusion causing cardiac tamponade, a very good view is obtained in this position. So next is inferior vena cava view, and that is one of the most commonly used part in the transthoracic echocardiography at the bedside in ICU. So for any patients who are in hemodynamic instability, who are in shock, we as part of our routine examination, we always see the IVC. So how we are going to see the IVC? From the subxiphoid view, again the patient still in supine position, knee bent, right atrium in view, liver in the center. We change the probe position from the pointer towards the right side. We tilt the probe anti-clockwise 90 degrees, so the pointer is at the 12 o'clock position, and we will see a nice IVC opening into the RA, this one. So from here we shifted anti-clockwise, and this is RA, This is IVC, and the hepatic vein also, most of the time we see opening the hepatic vein in the IVC. So that is like a Trishul. So that's a very confirmatory point that it is inferior vena cava. At times we might get confused with the aorta, because if we will tilt the probe little towards the downward side, we can see aorta also, iota also. So we can misinterpret it as IVC, and because aorta is always full, we can say IVC is plethoric, so patient may not be fluid responsive. So always confirm it when IVC is opening into the RA, and you will see the hepatic vein also. So this is the IVC diameter using the M mode. So once this, we are seeing the IVC here, we will put the M mode and we see this picture. We need to see the diameter in inspiration and expiration. That is important. If the patient is spontaneously breathing, we will see the collapsibility. If the patient is on mechanical ventilator, we will see the distensibility. So that assessment is important for estimating the fluid responsiveness in hemodynamically unstable patients. So here we can see nice IVC, hepatic vein getting opened in the IVC. Next is suprasternal view. Again, not very commonly used view in critical care medicine point of view, but we can again see this view. So this is the transducer position, patient in completely lying down, nothing beneath the head. Slightly lift the chin, ask the patient to turn the head slightly towards the left, and put your probe at the suprasternal notch with pointer towards the 2 o'clock position. So these are the structures we will give. So it will give a very nice look of the ascending aorta, arch of aorta, descending aorta. So at times, if we are strongly suspecting any dissection, so we can use this view to see any aortic dissection in this part. Also, brachiocephalic vein and the right pulmonary artery are visible nicely in this position. So that is from the all transthoracic views in the ICU. Obviously, clinical impact, it has evolved a lot as we are using transthoracic echocardiography bedside for almost each and every patients. Whenever there is any hemodynamic instability, or whenever there is a patient coming with the breathlessness also, or any chest heaviness, it is immediately available. So it gives a real-time data on cardiac output, ejection fraction, preload assessment, essential for managing shock. Also in differentiating the patients from the cardiogenic versus non-cardiogenic shock, so that we can give the appropriate treatment. So future of this future, how we are going to evolve here in transthoracic echocardiography and ICU. So obviously advanced imaging techniques are coming, where there will be more precise images, 3D images are available, then integrating it with other modalities which can provide more comprehensive assessment of the critically ill patients, and obviously training and educations in this part in critical care also. So to conclude, this invaluable tool in critical care medicine that offers very rapid, non-invasive assessment of cardiac function and structures at the bedside. That is very important, because in ICU, most of the patients are unstable, so they cannot get shifted to, and also many patients, it is non-invasive. Those who cannot afford but are in ICU, 2D echo is available. So we can use it bedside without adding to the cost. And it's crucial role for timely diagnosis, because if the patient is coming at any point of time in the ICU, whether it is day or night, whether any other cardiologist.
Please mute.
If from the ICU point of view, even the ICU team who knows at least how to see the ejection fraction and the IVC. So at least in the emergency time, we can tide over that crucial situation and manage the critically ill patients, providing essential information that can guide us therapeutic decisions and improve the outcomes in the IC critical care patients. So that's all from my side. I think I finished it off very soon, fast. So
Yeah, thank you, Ritika. That was a wonderful talk. And I think, am I audible?
Yes, sir, you are audible.
Yeah. So that was a wonderful talk. And I think before any talk on any point of ultrasound in the intensive care unit, we must highlight that it answers a clinical question. Okay. Second is it has to be integrated into clinical decision making. And third is this skill is a part of clinical examination. Nobody can do without it. So the entire ICU team must undergo appropriate training, accreditation, and have the privileges and do the things in the correct manner. So that's all from my side. And I suggest that every unit should have a small performer which people fill up, and so then the unit gets tuned to what you want to see, whether you want to see the EF, the VTI, or you want to see the IVC. So that's all from my side. If there are any questions, we can take the questions now, or I hand over back to the chairperson.
Yes, anybody, if you have any question, you can please ask.
Ma'am, just doubt regarding how to differentiate coronary sinus from the.
So, as I told you, if we are tilting the probe too much and we are seeing, we can put a Doppler also so that we can see whether there is any atrial septal defect, and we can tilt the probe so that we can get a good 4-chamber view. And there we can see whether there is any atrial septal defect is there or not. So that's how we can. So what do you say, Vivek sir?
See, for the coronary sinus is not routinely imaged. However, if you have a dilated RA and RV, you will see a huge coronary sinus. That is one, easier to see. Second is if you have a patient who's got a implanted cardioverter or defibrillator, probably.
Sorry, you are muted. But if there is any biventricular dysfunction, so
Sorry.
that there's
So,
yes, sir.
yeah, so normally in the intensive care unit, we don't see the coronary sinus view. It's if the RA and RV are dilated, you will automatically see the coronary sinus. In case the patient has got an implanted cardioverter defibrillator, again, you will see one of the leads going into the coronary sinus. So beyond that, there is no need to image the coronary sinus. If you have some ASD or a PFO, you can see the septum, and the septum can be seen in either the subcostal view or the apical 4-chamber view, and you can easily manage with that.
Thank you, sir.
Thank you, sir. Thank you, Dr. Ritika. Thank you, Dr. Vivek. So let's move on to our next lecture. I welcome Dr. Talla Meeran for the lecture. He is a consultant cardiologist at Sir H.N. Reliance Hospital, and he has done MD medicine with FACC cardiology. He has done fellowship in general cardiovascular medicine, Allegheny Hospital, USA. He has done fellowship in advanced heart failure, transplant cardiology, pulmonary hypertension, and mechanical circulatory support, Allegheny Hospital, USA. So we are glad to have him here on the platform. He is going to enlighten us about the transesophageal echo. Welcome, Dr. Talla. This session will be moderated by our Dr. Rahul Pandit, our guide and our chair. Dr. Talla, you can start. I think you are muted, Dr. Talla.
Are my slides viewable now? Can you see my slides?
Yeah, they are visible. Okay,
perfect. Hi, good evening, everyone. Thank you. I didn't hear the entire bit of the last presentation, but whatever I heard was very insightful and helpful. So the basic idea of today's talk is to get everyone in the ICU team comfortable with the basic views of transesophageal echocardiogram. We're not talking about advanced views like we were mentioning here, corny sinus. We don't want to look at all those things. Basic things we will go over. So before we start, we'll just quickly go over, I won't spend too much time on this, briefly indications for TE. The biggest indication for TE is when you don't have a good acoustic window for a transthoracic imaging. So that's when you resort to TEE. Now, in those settings, what are some of the other indications that typically we come across, especially in the ICU setting, is number one is infective endocarditis when you're looking at intracardiac vegetations. So there are a couple of clinical scenarios where you would opt for a TEE. Number one, when you do a transthoracic echocardiogram, you don't find anything on a transthoracic, but your pretest probability is very high. So then you would definitely resort to a TEE. When you want to look for complications of infective endocarditis, whether it be valve dehiscence, valve rupture, valvular abscesses, those kind of things where you want to look at with TEE. Other and also commonly done indication is when patients are already on treatment with antibiotics for infective endocarditis, and if the treating team thinks that there is inadequate response, or if there is a change for the worse in the clinical condition, then you would want to do a surveillance TEE just to make sure that there is no small, abscess that's developing or a small valve perforation that's developed, because those all would change the management and would sort of be indications for surgery. Other indications that you would see is precardioversion or radiofrequency ablation for SVT or even atrial fibrillation. The most important thing is you don't not only want to exclude clot in the left atrium, but also in the left atrial appendage. The left atrial appendage is not very well seen in the transthoracic echo because it's a very posteriorly placed structure, anatomically speaking. So because we are approaching in the TE from behind the heart, from the esophagus, we are able to visualize the left atrial appendage very well, and hence exclude a left atrial appendage clot with nearly 99% sensitivity. This indication is particularly getting more and more common in these days. You will see less of this in the ICU, but more in the cath lab doing structural heart interventions like MitraClip, TAVI, Watchman devices, which are left atrial appendage occlusion devices, ASD and VSD closures. In certain cases, again, not more common in the ICU, but this is sort of more of an OPD basis indication when we are evaluating valvular lesion, especially of the mitral valve. Again, mitral valve is posteriorly placed structure, so we get beautiful images of the mitral valve, and especially this prosthetic heart valves. A lot of times on transthoracic imaging, because the prosthetic heart valves, their struts, or if they're metallic leaflets, they cast a lot of shadows and impair vision behind those valves. So through different angles, we can look at those hidden structures and get more anatomical delineation. Cryptogenic stroke is common, so ruling out a left atrial appendage clot, PFO, or any aortic arch atheromas. Cardiac masses, very, very helpful TE to basically define where the mass is located, what structures are attached to it, whether there is any infiltration into the pericardium, myocardium, valves, and also what kind of hemodynamic impact it could potentially have, the mass on the LV and RV filling. This is most the acutely ill post-MI patients or post-cardiac surgery patients, especially when you don't have good transthoracic windows. TE can often be very helpful. And congenital heart diseases, there are certain kind of congenital heart diseases which you cannot really rule out on a transthoracic. Especially something like a sinus venosus, ASD, anomalous pulmonary vein drainage, especially in adults, you would definitely need a TEE. Another common indication is for ASD closure. Prior to ASD closure, when we are trying to see if it is feasible to close this via percutaneous approach, we need to make sure that the ASD has enough rims, superior and inferior rims, so that these devices fit and stay put and don't embolize. So very important application of the
Tala, Dr.
Yes,
Pandit
sir.
here. Can I just interrupt for a second?
Yes, sir.
आप थोड़ा सा ECMO कैनुला पोजीशन भी बोल दो ना, इंडिकेशन में क्या क्या करना पड़ेगा. That's relevant to ICU as well. Thanks.
वो बाद में आएगा sir. I have a few clips, but anyways, so as sir mentioned, ECMO cannula positioning is also extremely useful indication or application of TEE. Venous cannula as well as the arterial cannulas. So the venous cannula you can see when you are, even with the transthoracic echocardiograms, you can mostly see it if the patients have a good subcostal window. With the arterial cannulas, if you're doing it at the bedside, transthoracic may not be very helpful because you can't really appreciate how far up you have gone in the aorta. So that may be, an important application. For VV, we know venous ECMO. If you have good windows, then transthoracic echo is fine. But if you have the sort of ability that TE is readily available in your ICU setup, then definitely one must try to do it with the TE guidance. Now, the single lumen cannulas, the VV ECMO cannulas that we put it through the IJV, they should never be placed at the bedside without TE guidance. If you do not have TE, then you must do it in the cath lab under fluoro guidance, because it's extremely important to know where the inlet and outlet of the dual stage cannula for VV ECMO is located, and you cannot really see that with a transthoracic echo, no matter how good your windows are. So that would be one exception for a VV ECMO where you have to use a TEE. Moving on, we're talking about absolute contraindications. So these are the absolute contraindications. There are very few. These are all common sense things. If you've had recent oropharyngeal or esophageal surgery, any obstructive pathology in the oropharynx or esophagus, suspected esophageal perf, esophageal diverticulum, or if there is active bleeding from the stomach or the esophagus or from esophageal or varices. These are some of the relative contraindications. Again, they are very common sense things. Loose teeth, gum injury, inability to open the mouth widely, non-bleeding ulcers or grade 1 or 2 esophageal ulcers, esophageal varices, hiatus hernia if patient is coagulopathic but not actively bleeding, cervical spine arthritis. Again, it's just a relative contraindication. Now, one or two caveats regarding these esophageal and gastric varices. There have been certain cases where we have been able to do TE even in patients with known varices, provided they are not actively bleeding. So generally what we do is we ask our gastroenterology colleagues just to put in a quick probe with their upper GI endoscope and quickly look at what the position of the varices is. So number one, just to make sure they're not actively bleeding. If they're actively bleeding, no ways we should do a TE. If they're not bleeding, then we ask them to just delineate how far those varices are from the incisor. So when we are doing our TE, we can make sure that we are above the level of the varices. If they're higher up in the esophagus, like if they're say around 25, 30, or maybe even below sort of 30, 35 centimeters, it will be difficult to get good views. But if say they are beyond 40 centimeters from the incisors, then you should be able to get good views from the TE without damaging the varices or causing any active bleeding. So this is how a regular TE probe, usual TE probe looks like. You have this long flexible shaft. The probe has a tip which has got ability for multiplanar imaging, and the transducer handle has the controller housing. If you look at box number 2 over here, the controller housing has a couple of controls. The small wheel here is for lateral flexion, and I'll show you how that works. The large wheel is for anti-flexion and retroflexion. And these knobs here is to adjust the omniplane angles. When we talk about omniplane angles, those are the angles in degrees. We go from 0 to 180 degrees. So these knobs help adjust that. This is a lock lever. When you activate the lock lever, it fixes this probe tip in that position. Sometimes what happens, especially in patients who are intubated, they are not able to, so most of the insertion of the TE probe is by our active effort. Now, if they are intubated and if their tongue is falling posteriorly, and if this lever lock is not activated, then just because of the tongue falling back, the probe tip tends to do its own movement. So it can either go in extreme flexion or go into lateral flexion and get stuck in the pyriform fossa. So sometimes, not always, sometimes I may just use activate this lock lever and then guide the TE probe into the esophagus. Now, when we also now turning your attention to this figure in the upper right, when we talk about TE imaging, it is mostly done, most of your views are labeled or they are named according to where the TE probe is in the esophagus. So upper esophagus, mid esophagus view, and transgastric view. Upper esophagus is anywhere between 20 to 30 centimeters depth. Mid esophagus is anywhere between 30 to 40 centimeters depth. And transgastric is once you're into the stomach and you start seeing the gastric rugae and the folds. And there is also a deep transgastric view. We tend to avoid that. I think in an ICU setup, you can get most of your information by getting a good mid-esophageal views. And if at all, if you are not able to get good mid-esophageal views, then maybe just a simple transgastric without going too deep transgastric, you can get decent views using, in these positions. So the mid-esophageal and maybe the transgastric view. Now, this is what, when we talk about movements and manipulation of the TE probe, this is what I will be referring to. So there are a couple of ways you can move the probe, right? Withdrawing. So withdrawing means pulling the probe out of the patient's mouth. Advancing, meaning advancing the probe further down the esophagus into the stomach. Other thing that you can do is turning to the right. When I say right and left over here, it means the patient's right and the patient's left with respect to the TEE probe tip facing anteriorly. So this is the anterior part of the probe tip. So if I'm turning it right, it is going to turn to the patient's right. That's called a clockwise rotation. And if I'm turning it left, it's turning to the patient's left. That's called a counterclockwise or anti-clockwise rotation. Drawing your attention to the bottom two figures, these are the other two movements that are possible. I told you about anti-flexion and retroflexion. Anti-flexion, which is the anti-flexion and retroflexion, is with the bigger wheel on the controller housing. This wheel, this controls your anti-flexion and retroflexion, and the small wheel controls the lateral flexion, right and left flexion. So when we say anti-flex, anti-flex means the probe tip goes closer to the anterior part of the stomach, so closer to the ventral surface of the body. That's called anti-flexion, and the opposite is retroflexion. And this is pretty self-explanatory: right flexion and left flexion. Then the other thing is the omniplane angle. This is how the ultrasound beams are directed from the probe tip. So this can go from, as I said, from 0 degrees to 180 degrees. Certain other absolute basics that you need to know about TE imaging planes. I talked about the omniplane angles. So generally with the probe tip, so if you look at the right hand side image here with the transducer, so this is a mid-esophageal 4-chamber view. We'll discuss on how to get this and how it looks like. but this is a 4-chamber view with the omniplane angle at 0 degrees. So at 0 degrees omniplane angle, all the anatomic structures that are supposed to be on the left side, the left ventricle, will appear on the right side of your echo screen. Okay, so it's ulta. So the LV is appearing on the right side of the screen, correct? And the right RV is the other way. As you increase the angle, so from 0 to perpendicular 90 degrees, you are basically moving things in a counterclockwise direction. It's a little difficult to imagine. I have searched some 3D schematics after this to try to explain how the omniplane angle moves and how we are cutting at different planes. But if you can bear with me here and just imagine that if you are increasing the angle from 0 degrees to 90 degrees, the anterior surface moves more inferiorly. And as you go the full circle 0 to 180 degrees, it becomes ulta absolutely. And the LV is now to the left side of the screen, whereas at the 0 degrees angle, it was on the right side of the screen. So it's like a mirror image. If you look at the rightmost image and the leftmost image, they are basically mirror images of each other. So these are the TEE imaging planes. Why am I only talking about the mitral valve anatomy? Is because as I alluded to earlier, mitral valve is beautifully imaged with TE, and most of our TE that we do on an OPD basis for valvular lesions, we do it mostly for mitral valve intervention. So, mitral valve is not how it seems on our 2D transthoracic image. It's a wonderful 3D structure. It's classically described as in the shape of a horseback saddle or this kind of a chip. So the antero-posterior diameter is always shorter than the commissural diameter. So you look at this red line, the antero-posterior diameter is shorter than the commissural diameter. And in this 3D view, so these views over here, these are 3D views of the mitral valve. This is what we call the surgeon's view. We do not expect the ICU folks to get such views, but this is something that just the terminology and just the lingo you should get used to if you're doing TEs. So basically, this is the end. So this is the surgeon's view when the surgeon opens the left atrium and looks at the mitral valve. So imagine you are the surgeon and staring down an open left atrium into the mitral valve. So what is placed anteriorly is the anterior mitral leaflet, and what is placed posteriorly is the posterior mitral leaflet. These leaflets are then divided into scallops, A1, A2, A3, and P1, P2, P3. A1 and P1 are lateral, A3 and P3 are medial scallops. So whenever we talked about, flail leaflets or perforated leaflets on TE, we try to localize it for the surgeon. There is a flail of the A2, P2, or there is a perforation of the P3, and from there you can see the mitral regurgitation jet. Or for instance, there is a big vegetation with possible abscess formation in the A3, P3 area. Just some examples, that we would give. So just to get, everyone familiar to what we are talking about, I just wanted this up there. So the mitral valve and how it looks. AML, PML, and the scallops, A1, A2, A3, P1, P2, P3, going from lateral to medial. Now, these are some of the 3D schematics which we'll see. So, so if you see here on this figure, the TE probe is at the back, and it sends a ultrasound beam which is going in this plane. So if I slice open the heart and I look at it like that, so the ultrasound beam is cutting across the LV and RV as such. And then if I just turn the heart in a little bit, this is what your 4-chamber view looks like. Correct? So just going back, the ultrasound beam's traveling this way, and then you're slicing up the heart and just sort of tilting it forwards to look at it. So this is how it looks. So this is your mid-esophageal 4-chamber view at 0 degrees. You remember at 0 degrees, the left ventricle will be on the right side of the screen and the right ventricle will be on the left side of the screen. Okay. And then rest of it is self-explanatory: mitral valve, left atrium, and right ventricle. So this is a very good view to start with. I do have a live clip as well, I think. Oh, this is another 3D schematic I tried to put here. Hopefully this plays. Yes, so this is how exactly the four chambers. So the ultrasound beams going this way, and you're looking at the heart sort of just tilted. So just for your better understanding, you can see the TE probe on the left clip here, right at the back here, and it's sending those ultrasound beams at a 0-degree angle, directly anterior. And this is how an actual mid-esophageal four-chamber view would look at. So you're typically at a 0 degrees, maybe 0 to 10 degrees omniplane angle, and you're at a depth of anywhere between 30 to 40 centimeters. To open up the entire LV apex, you may have to a little bit anti-flex, just so that the LV apex opens up. Now, this view is an excellent view to make sure, in the ICU, to begin a sort of a, get a prelim view of the heart. When you look at this, okay, good. You know what the LV function is, you know what the RV function is, you know grossly that there are no big vegetations on the mitral valves, grossly there are no big vegetation on the tricuspid valve. However, you can't be absolutely sure because you need to look at all angles and all views. Remember, this is just a 2D view. Also a good view to look for any pericardial effusions. You can put color on this and also look for any VSDs, especially post-MI VSDs. You can also look for valve perforations, again, complications of acute MI. And you see a part of the interatrial septum as well. We have better views to look at the interatrial septum, but this gives you a rough overall idea. So this is going to be your bread and butter view. This should be the first view one must try to get once you insert the TE probe. So remember, 30 to 40 centimeters depth, 0 degrees omniplane angle, maybe a little bit of anti-flexion may be required to open up the LV apex. This is a mid-esophageal 5-chamber view. It's basically just it requires a small, tiny modification from the 4-chamber view. Whatever depth you are at with your 4-chamber view, just sort of pull the probe out, and you will start seeing the aortic valve here. And that's basically your mid-esophageal 5-chamber view. Okay, so 5-chamber because you see the 5th aortic root and the aortic valve. So that's why the mid-esophageal 5-chamber view. Otherwise, everything else is similar. Now, this is a mid-esophageal mitral commissural view. So generally, with the mitral commissural view, you are looking at different scallops of the mitral valve. So what valves of the what walls of the of the left ventricle do you see here? You see the inferior wall and you see the anterior wall. In this cartoon here, you will see that generally you should see an anterolateral papillary muscle and a posterior medial papillary muscle. This little bit here is the coronary sinus. Again, not very important. This is actually the left circumflex coronary artery. Again, not very important to visualize. What you need to see in the ICU is, yes, you need to understand that, boss, this is the anterior wall, this is the inferior wall, and this is the mitral leaflet. At different angles, you will see different scallops of the mitral valve. Now, this view you would typically obtain at an angle of possibly between 40 to 60 degrees and at the same depth. So you're at mid-esophageal 4-chamber view. From there, you simply just slowly increase the angle, and between 40 to 60 degrees, you should see this view. There is a live clip of this as well later. This is your classical mid-esophageal 2-chamber view. This is obtained at the same depth, but just if you increase the angle a little bit more from 60 degrees, perhaps somewhere between 70 to 90 degrees, you should see your classical mid-esophageal 2-chamber view. This is what a This is basically a mitral mid-esophageal two-chamber commissural view. So this is the anterior wall, this is the inferior wall, and you actually, in this view, so this is an actual clip from one of my recent teas, you actually see the left circumflex coronary artery as well. Had I increased the sector width, so increase the width, you can actually see the left atrial appendage also peeking in there. So this is your mid-esophageal two-chamber view. You can also loosely call it a mitral commissural view. Now, again, from that mid-esophageal two-chamber view, when your omniplane angle is at somewhere between 60 to 90 degrees, you keep on increasing the angle. As you're increasing the angle, make sure that your probe is steady so that your image, your LV, is in the center of your screen. And as you hit somewhere between 110 to 130 degrees, you should start seeing the long axis view of the LV, of the left ventricle. Okay, so in this view, the LVOT, the left ventricular outflow tract, opens up and you can see the aortic valve and the aortic root. Now, why is this important? Again, you're seeing different scallops of the mitral leaflet here. So, there are sometimes especially when there is a flail or a mitral prolapse, you may not see it on your mid-esophageal four-chamber view. You may see it here because these are completely different. These are the A2, P2 scallops, which are not seen on the your mid-esophageal four-chamber view. So, in doing a thorough TE, it just involves looking at all the valves and all the structures at different angles. So over here, you're looking at the anteroseptal wall here, and this is the posterior inferior wall. And this is the mitral valve, left atrium, aortic root, aortic valve. Yes, so this is a live clip of a long axis view. So you, with a simultaneous color Doppler on the right side of your screen, you see the mitral leaflets, you see the aortic root and the aortic valve. What you see over here, a little bit of the right ventricular outflow tract is what you see on this side, just to the right of the anteroseptal wall. Now, this is just a minor modification. So the initial view, the previous view is called the mid-esophageal long axis view. This is called the mid-esophageal aortic valve long axis view, simply because we are focusing on the aortic valve here. Okay, so same view, same omniplane angle, maybe just withdraw the probe, maybe 5 to 10 centimeters, not more than that, and reduce the depth so that you're focusing on the aortic valve, and you may have to rotate it towards the right so that your aortic sinuses become nice and symmetric like this. So this is an example of a aortic valve long axis. So nice and symmetric aortic sinuses, your aortic valve, and you can, if you, in this view, if you withdraw your probe further, you will also see a very nice and horizontal ascending aorta as well. That would be a good place, and even in fact, this view would also be a good place to look at the VA ECMO cannula when the arterial cannula is placed in the axillary artery. So the axillary artery somewhere in the ascending aorta, or the arch is where you would see the flow. So you may not see the cannula, but you may see the flow coming back. This is the mid-esophageal aortic short axis view. For this view, what you would have to do from this view, from the aortic valve long axis view, remember the angle, omniplane angle is around 110 to 120 degree. In this view, you may have to withdraw the probe and reduce the angle to somewhere between 40 to 60 degrees, and a little bit of clockwise or counterclockwise, right or left rotation, so that you see the aortic valve leaflet. So this is a beautiful view. I feel, in my opinion, this is the most beautiful view that you can see on the TE. You can see the aortic valve with the nice Mercedes-Benz sign. You can see the pulmonic valve here, and you can see the tricuspid valve. So this view gives you a lot of information. So just sort of ingrain this in your head. The aortic valve, nice Mercedes-Benz sign. This is the RVOT, and the pulmonic valve and the tricuspid valve. Very often we use this view in the operating theater when we cannot pass the Swan-Ganz easily. So you should see your Swan-Ganz coming in from here in the right atrium, from your SVC into the right atrium, across the tricuspid valve, and go right across the pulmonic valve, across the RVOT into the PA. So this is sometimes very useful in the operating theater, this view. This is just a live example of the aortic valve short axis view. Remember, from the aortic valve long axis view, you may have to withdraw the probe a little bit, or maybe not, and just reduce the angle from 110 to 40 to 60 degrees. You see the aortic valve on the right, pulmonic valve, and here the tricuspid valve. All right. This is one more standard view. This is called the mid-esophageal bicaval view. How do I get this view? So from this previous short axis view, you again increase the angle to 100 to 120 degrees and do a clockwise rotation, and you will see this nice bicaval view. Okay, so this is your SVC, this is your IVC, this is the interatrial septum. On the top of the screen, close to the probe, what is the closest to the probe is the posterior most structure, which is the left atrium. And what is away from the probe is the anterior structure, which is the right atrium. Okay, so left atrium, right atrium. What you see a little bit over here is the right atrial appendage. This is the crista terminalis, which is right at the junction of the SVC and the RA. Sometimes close to where the IVC is, you can see a prominent eustachian valve, which you may mistake for a clot or a vegetation, but generally, it looks very different, very thin and linear and hypermobile, the eustachian valve. This view and a modification of it, I think I have it in a couple of slides, is very, very helpful when you're doing your VV ECMO, to make sure that your drainage cannula and your return cannula are in the right position. Obviously, this view we also look at to see if there is a PFO or not. Okay, so this is the standard bicaval view, very, very useful view. So I think in terms of standard views, we are covered with all. I just like to go over everything once more. You start with your mid-esophageal 4-chamber view. You are at 30 to 40 centimeters depth, 0 degrees angle. From here, keeping the probe at the same depth, you start increasing your angle. So between 40 to 60 degrees, you should start seeing your 2-chamber view and your mitral commissural view, which looks like this. Okay, this is the anterior wall, this is the inferior wall. From this position, as you start increasing the angle, you go to the mid-esophageal long axis view. Typically, you'll get it between 110 to 120, maybe 130 degrees. This is how it looks like. Long axis view, you open up the LVOT and the aortic valve. You're looking at different scallops of the mitral valve. You're looking at the anterior septal wall and the posterior lateral wall. Okay. From this view, you want to focus, if you want to focus on the aortic valve, if you're looking at vegetations in the aortic valve, you may have to withdraw the probe a little bit, and clockwise at the same angle as the long axis view, you should be able to get this aortic valve long axis view. Okay. And then from there, I told you this is the most beautiful view in my opinion. Just keep it at the same depth, maybe have to withdraw a little bit, but mostly keep the probe at the same depth and reduce the angle again. For the long axis view, remember, you are between 110 to 120 omniplane angle. For this, you may have to go anywhere between 40 to 60 degrees on the omniplane angle and get this beautiful aortic valve short axis view. Okay, particularly useful when you're stuck with a Swan-Ganz, not advancing. Yeah. And then this is the bicaval view. So from the short axis view, you have to rotate clockwise, meaning towards the right, and increase the angle to anywhere between 90 to 110, maybe 120 to get this bicaval view. very useful for VV ECMO. Now this is, as I was telling Dr. Pandit sir about this. So this is actually one of our patients only where we were doing a VV ECMO. So from the bicable view, how to get this view? So this view does not have a name. This is just a modified view. From the bicable view, so the same bicable view at 110 degrees, you just advance the probe. You advance the probe until you see the liver parenchyma and you start seeing the hepatic veins. So that is where you are coming into the abdominal portion of the IVC, and that is where you would see your femoral venous ECMO cannulas. So this is very, very important for VV ECMO cannulation to make sure that we are not we are at the right position, we are not occluding any hepatic veins, and we are just about at the IVC RA junction, or maybe if you want to be a little bit more in the RA. So this is a slight modification from the bicable view. I don't think it has a proper name for this view. So this is for the VV ECMO. This is the only transgastric view I thought was worth mentioning, especially for from an ICU perspective. I think if you follow all of the directions that I mentioned in the previous slides, you should get adequate information about your NV, LV, and RV. So you don't have to venture into the stomach. Going into the stomach, you may, slightly increase the chance of, complications from your TE, gastric perforation, and whatnot. So always advisable to try to get your study done from the esophagus, until you get more skilled and you know exactly how much pressure to apply with the TE probe, because this is not small like an RT. This is a much thicker probe. You can do damage, rarely, but you can. So in this view, basically just adjust your omniplane angle to 0 from your mid-esophageal 4-chamber view. You just advance the probe until you feel a little bit resistance, and then you start seeing the gastrorugal folds. And from there, you would have to anti-flex. Remember, anti-flex is when your probe angle goes anteriorly towards the stomach. So say this is the esophagus and this is the probe and this is the stomach. So you're going behind and you're anti-flexing the probe tip so that it touches the stomach, and this is the view that you would get. So in this view, this is the orientation. Closer to the screen is the inferior wall, and away from the screen is the anterior wall of the left ventricle. You see a part of the right ventricle as well. Okay, so inferior, inferolateral, inferoseptal, anteroseptal, and anterolateral. So these are the LV segments that you would see here. Another sort of modification to the standard views could be important when you are putting maybe a VA ECMO or a Swan-Ganz catheter. This is the mid-esophageal ascending aorta short axis view. This is not in no ways an easy view to obtain. This can be quite difficult. If I were to give you the simplest directions, I would say at 0 degrees, when you're getting your mid-esophageal 4-chamber view, just withdraw the probe a little bit, and you may have to do a little bit of counter flexion to get this kind of view, where you would see the right pulmonary artery, the main PA, and the ascending aorta. So typically, and this is the SVC. So typically, if you are, trying to see if there is, if your arterial ECMO cannulas are placed okay, you should generally see the flows, if not the cannula, at least the flows in this part of the ascending aorta by putting in a color Doppler, and the RPA and main PA, just to make sure, where your Swan-Ganz would be. So this, I think, is the, I would not worry about this. That I think is the last sort of standard views among the TE. I think I'm going to stop here, and I would take any questions if there are from the audience.
Anybody has any questions for Dr. Talla? I think nobody has any questions there. I
Okay,
think it was a beautiful and elaborate, exhaustive presentation. Thank you very much, Dr. Talla. I'm sure this lecture is going to help people to understand the views during the hands-on session.
So Tushar, Vikrant, I'm there. Thank
Okay.
you. It's a very nice presentation. Thank you very much. And I think the introduction to transesophageal echo is very important from ICU point of view. And I would urge all of you to practice this on the mannequin, which we are going to get for the hands-on practice, which we have on Sunday. Sorry, not Sunday, Saturday, beg your pardon. Please make sure that if you have any doubts, write it down and send it to Dr. Vikrant. He will be happy to convey it with Dr. Talla and we can answer those doubts, or Dr. Talla can sort of send some relevant information if required. But it's very important for you to understand the anatomy and the views of the transesophageal echo as an intensivist. There is no role to say that I don't know what it is. Talla, thank you very much for the informative lecture. Thank you really very much.
Most welcome, sir. Most welcome, sir. So just for in preparation for the actual the mannequins and the simulators, hopefully one has jotted down some points. Just make sure that you know where to find your images, the depth and the angles, and just by repetitive performance during the workshop, that is when you are going to get used to it. Just reading books is not going to help, because the feel of the probe, how much flexion, how much rotation, those are completely different sort of things from just reading. So and typically the kind of adjustments that you make to the probe as compared to a transthoracic echo, a transesophageal echo probe needs very, very, very little manipulation to get drastic changes in your images. So you have to be very, very fine with your movements as compared to a transthoracic. TE is a little bit more nuanced and requires finer movement. So just make sure that we are maybe going through quickly over just the jotted points and before you come to the actual simulator workshop. So hope to see you all there. Thank you. Thank you to all the organizers and to the entire ICU team here. Thank you.
Thanks,
Thank you,
Dr.
Dr.
Talla. Thank you. Thank you. Vikrant, over to you. Can I log off?
Yes, sir. Sure. Thank you very much.
Thank you, Vikrant. Thank you. Bye.
I'll be there.
So next we have Dr. Jitendra Chaudhary with us. He's going to take sonographic approach to shock. He has done FNB critical care and European diploma in intensive care. He's a very, very efficient intensivist and is a very good academician. So welcome, Dr. Jitendra. You can please proceed with your presentation.
Thank you, Vikrant. My screen is visible?
Yes, it is visible.
Right. So today, I think we have gone through many lectures. We have seen the basic use of the echo. We have seen the use of ultrasound in trauma. Here, I'm trying to just amalgamate all the knowledge we have gathered, because the ultimate question which everybody at the bedside faces is, what is the reason of the shock, right? Shock is a state of a circular dysfunction which causes a reduction in the tissue perfusion and causes a metabolic upset. Now, there are various causes of shocks. The shock could be because of a hypovolemic shock, hemorrhagic shock. It could be distributive shock. It could be cardiogenic shock or obstructive shock. Now, whenever you are tackling a patient with a shock, the biggest question in front of you is, what is the etiology which you are dealing with? Which kind of a shock you are dealing with? Diagnosing this etiology is a very, very challenging, because many a times it is not just a one cause of the shock. There could be multiple causes which are working simultaneously. Now, the studies have shown that point of care ultrasound has actually increased your diagnostic accuracy for the diagnosis from a 45% to 89%. Mind you, the goal of focus in this situation is to narrow the differential diagnosis, increase the diagnostic accuracy, and monitor the response for intervention. It is not the test which will determine it is always along with your history, physical examination, and monitoring. The focus will help you in increasing your diagnostic field. Now there are various protocols which are available which can be used. The most commonly used is a RUSH protocol. RUSH is your rapid ultrasound for shock and hypotension. The main components of the RUSH protocol are: you look at the pump, you look at the tank, and you look at the pipes. So pump is your heart, tank is tank is your IVC, inferior vena cava, lungs, abdomen, and pipes is your veins and aorta, right? So when we will go through one by one. When you are looking at the pump, the main views which we will be using is parasternal long axis, parasternal shock axis, the zephysteroid and apical views, and mainly you are focusing on the heart. The questions you will be asking yourself is whether there is any cardiac tamponade or a pericardial effusion, whether there is any, how is the ventricular contractility, and whether there is any RV dysfunction. So the first question is there any pericardial effusion? So the commonest view which you see is either zephysternoid, subxiphoid view, four-chamber views, or a parasternal views. There could be some pericardial effusion. Now, many times it may be a bit difficult to differentiate between pericardial effusion and a pleural effusion. The thing which we need to focus on is your descending aorta. If your effusion is above the descending aorta, then it is a pericardial effusion. If your effusion is below your descending aorta, then it is a pleural effusion. Along with the pericardial effusion, the most important question you want is whether there is any cardiac tamponade. So a big pericardial effusion which is causing your diastolic collapse of your RV, or a systolic collapse of your RA will indicate that there is a pericardial effusion. Along with this, you are definitely going to look at your IVC. If your IVC is full with such a big pericardial effusion and RV collapse in your diastole, then definitely patient is in cardiac tamponade. And then the next question you ask yourself is, how is your LV contractility? Now here we are just eyeballing ourselves. We don't want exact ejection fraction. We want to know whether LV is hyperdynamic, LV contractile is normal, or it is reduced. So there are various things which can determine whether how is the contractility, whether your both the your LV cavity is decreasing, narrowing, whether there is any thickening of your LV during contraction, or whether your mitral valve leaflet reaching to a LV will indicate your amount of contractility. In case of a reduced contractility, there will be any decrease in your LV cavity. While you are looking at a hyperdynamic heart, both the valves of your LV will be kissing each other. The next question you ask yourself is there, how is your RV function? Is the RV acutely dilated, or is there any D-shaped septum, or whether its septum is pushed toward LV? Normally your septum is LV septum moves into your RV, and it is a crescent shaped RV with a circular LA. When your RV pressure is dilated, your left septum is pushed towards LV and it is flattened. So we call it a D-shaped septum. Along with that, what you see is sort Macklin style, where your apex of your RV is collapsing during your diastole. So this indicates there is an increase in the pulmonary hypertension. Your RV dysfunction is there. Next question you ask yourself is, next point you look at is how is the tank? The things you look for in the assessing the tank is your inferior vena cava, your lungs, and your abdomen. The probes which you use are either curvilinear probe or a micro assay probe for your abdomen and IVC, and your linear probe for your lung assessment. The first question you ask yourself is whether the tank is full. So you will look at the IVC. Now, IVC, the most commonest view will be subxiphoid, where you will see the IVC. IVC could be plethoric, whether it could be a full in case of an overloaded situation, or it could be a completely collapsing IVC with a lot of respiratory variability and respiratory collapse in case of a hypovolemic or a distributive shock situation. The next question is whether the tank is leaking. So you will do a fast examination. You will look at the Morrison's pouch. If there is any free fluid in the tank, then it indicates that there is a leak. Along with the collapsed IVC, it indicates that patient is probably in a hypovolemic shock. Mainly the fast examination will be used in cases of a trauma. But here we are looking at the non-traumatic causes of a leakage, such as your rupture of your aortic aneurysm or your ectopic pregnancy rupture, which has caused a fluid leakage into your abdominal cavity. So you will see a free fluid in the Morrison's pouch. The other thing which will help you in the fast examination is whether the system is overloaded. So what you will look at is there will be a large pleural effusions, there could be large ascites, your lungs will be flooded. So there will be a lot of B lines on the lungs ultrasound. So these are the signs which indicates that patient is overloaded, and probably it could be a component of a cardiogenic shock. The next question for your tank examination you will be asking yourself is whether the tank is compromised. So the most common reason for a compromised tank is a pneumothorax or a tension pneumothorax, which causes your sudden hypotension. Now, ultrasound examination for a pneumothorax, the most common thing which we'll be looking for is absence of your lung sliding. Along with that, if you can see a lung point, then definitely that indicates that there is a pneumothorax. Along with the absence of a pleural lung sliding, you will like to put a M mode, which will show you a stratosphere sign. This indicates that there is a pneumothorax. Along with the pneumothorax, if there is a large hypotension, sudden hypotension, that can give you a reason or indication that probably patient may be in a tension pneumothorax. The next thing you next thing you will like to examine while you do a rush examination is you look for the pipes. So pipes is you will be looking for aorta, and you're going to look for your deep veins. So whether there is any ruptures in the pipe, like your aortic aneurysm or dissection. So the important structure which you look for is you are going to use a curvilinear probe in the abdomen. The structure which you look for is your spine, and the structure which is immediately adjacent to or above your spinal shadow is your aorta, and structure which is adjacent to it is your IVC. Now, whenever you eyeball, if your aortic size is more than half of your spine diameter, then you think about a aneurysm in this scenario. Along with the aneurysm, this is a big aneurysm you are seeing, which is around 4 to 5 centimeter of a size of aneurysm. You can also sometimes see a aortic dissection flap, which is obviously seen. on the examination of aorta. The next most important thing which can give rise to a shock and which originates from the pipes is your deep veins. So you will be looking for a deep veins mainly in your femoral and popliteal sides. Along with that, your upper limb veins. So whenever you're looking for a venous thing, you want to see where you can obviously see a thrombus or a non-collapsibility on a compression of a veins. Like you're seeing in this first image, there is obvious thrombus you can make out. Along with that, your vein is not getting collapsed under the pressure. This is a very big thrombus which can be easily seen and make out. There is no need to do a collapsibility or compressibility test here also at all. So this is a big thrombus which is there. This big thrombus on the background of a sudden onset hypertension with a RV dysfunction will indicate to a pulmonary embolism. So the diagnostic strategy is when you examine all this thing, you will have to piece things together. On a pump examination, if you're looking at a hyperdynamic LV with a collapsed IVC, then probably you're looking at a hypovolemic shock. If there is a global decreased contractility, reduced ejection fraction with a over-distended system, it is probably a cardiogenic shock. If along with that, there is a sudden hypertension, RV strain, obvious DVT, then you are looking at probably pulmonary embolism and distributive shock. The mnemonic is, all these things you have to do very quickly at the bedside. You are looking at probably couple of minutes of examination, because this is many times a crashing situation where you need to find the answers to very quickly. So the quick mnemonic which you are looking at is HIMAC. So you look for the heart. In heart, you look for how is the contractility, how is the RV, and whether there is any cardiac tamponade. IVC examination, you look for whether IVC is over-distended or IVC is collapsing. In a fast examination and Morrison approach, you are looking for any leakage or any non-traumatic causes of a leakage in your abdomen and free fluid in the abdomen. In an aortic examination, you look for any obvious aortic aneurysm or aortic dissection. And pulmonary examination, you look for a pneumothorax. And I will like to add in this, along with that pneumothorax, probably you will look for a B lines or rockets, which will indicate that probably patient may be in a overload. Now, pitfalls of this examination is no focus or ultrasound examination is give you complete picture. So it is only adjunct to your clinical examination. So when you take the history and you, along with the history, you put this ultrasound findings, the answer becomes easier. Sonography is not for the novices. You will have to know your limitations in interpreting the scans. You cannot do the ultrasound for the first time and say you are yourself as an expert in interpreting the scan. The signs, the next pitfall is whenever you're looking for a signs of RV dilatation, you need to know the patient's history. If a patient is a chronic COPD patient or a past history of a DVT and have a chronic pulmonary hypertension, then your signs of RV dilatation and strain may not be very reliable in this scenario. So again, our history is a very important aspect in getting the information from the images which we acquire. The most important thing is you have to look for multiple views to get the information. You cannot base your assumption based on a single view, because single view may give you a completely different idea. Ultimately, the goal of the focus is to find a diagnosis, and it is not an alternative to your comprehensive examination. So both your examination, clinical examination and ultrasound examination go hand in hand. It is your extension of physical examination. So if a patient with a chest pain comes to you, you will have to take a history first. You cannot ask for ultrasound directly. All right. Any questions? I think I finished my presentation. If you have any questions, I'm happy to answer these.
Any questions, anybody?
Hi, sir. So I have a question regarding diagnosing PE, pulmonary embolism in emergency.
Right.
So, which is the ideal views we need to? One is design, second is RARV dilatation. So
Right.
RARV dilatation, we are looking at the four-chamber view, apical view, or which view is good enough to diagnose PE?
So, see, the easiest view to get in the ICU or an emergency department is your subcostal subxiphoid view. So I would definitely like to get that view first. If there is definitely, it looks like your RV is dilated. So I definitely eyeball myself. If your RV size is equal to your LV size, and definitely probably you're looking at an increase in the RV size. Along with that same subxiphoid view, I will definitely like to get a four-chamber view. If you are able to get a good four-chamber view, and in both the views, your RV is distended or dilated, then definitely that indicates that there is a RV strain. Then in this scenario, then you can put all this Dopplers and major TR and try to find out your pulmonary pressures. And then all your 60 by 60 rules and everything comes into picture. But if you want to ask the views, then probably I will start with the subxiphoid view first, and then I will try to get a four-chamber view.
And one more, sir. So only in massive PE we can sense this dilatation, right? In case
Yes.
of intermediate or mild PE, we can't rely focus, right?
So if it is a very, very small subsegmental pulmonary embolism, you may not get a echo finding immediately.
Okay.
But again, ultimately, it is a clinical scenario where patient had a very short period of short history, sudden onset of breathlessness after mobilization. Then a clinical suspicion comes into play, even if the patient's RV and echo is normal.
Okay. Thank you.
In fact, Akhil, we have seen one case. In fact, me and Dr. Jitendra had seen one case where initially there were no RARV dilatation, but as the time progressed, it was evident as the embolism, it involved the main trunks. It was initially maybe segmental, subsegmental. So we have to keep monitoring and vigilant and look at the overall clinical picture, and ultimately CT with IV contrast is the definitive.
Good,
Thank you very much, Dr. Jitendra.
Yes.
You want to add something?
No. Yeah, thank you.
Let's move on to our next topic. It is basically sonographic approach to the respiratory failure. And I welcome Dr. Sudipta Mukherjee and Dr. Darshana. Dr. Darshana is Additional Director at Sir H.N. Reliance Foundation Hospital in Critical Care. Over to you, Darshana, ma'am.
Yes, thanks, Vikrant. I welcome Dr. Sudipta Mukherjee. I have met him recently in this year already, just very recent at EuroAsia also. And he's the consultant and head of critical care at Tata Medical Center, Kolkata. And he has very good experience, and I have seen him presenting abstracts. In fact, even in EuroAsia, he had already presented a very good abstract. It was a very nice one. So he will be highlighting on lung ultrasonography, which is also going to be the most important aspect, which we see on a day-to-day basis. Over to you, Sudipta.
Hello, madam. Good evening. Good evening, everybody. Thank you for your nice words. And with your permission, I'm sharing the slides.
Go ahead.
Sure.
Having trouble sharing?
Just 1 second. Yes. My slide
Yes,
visible?
we can see. Yes, seems. Go ahead.
Yes, it is visible.
Great. So, hello everybody, and next 30 minutes or so, I will talk about lung ultrasound and sonographic approach to respiratory failure. So, whether lung is suitable for ultrasound, if you go back in the history 30 years back, even Harrison has mentioned that lung is a major hindrance for the use of ultrasound at thoracic level because we know that ultrasound cannot pass through air. But eventually we learned with the hard work of Daniel Lichtenstein that it's a misconception, and even the drawback of ultrasound while passing through the air has been utilized to develop a subspecialty that is lung ultrasound. And this is one of the earliest paper when it has been evaluated for its scope and usage. And over the last 3 decades, we have learned that with the use of lung ultrasound, it can help us in our clinical assessment in a multiple way. It can cut down the usage of CT scan as a rescue measure. It can limit bedside radiology. It decreases radiation doses as we are not doing X-ray and CT on a regular basis. It can help us to perform thoracentesis in a safe manner. It can diagnose pneumothorax. It can work on acute dyspnea, even in pericardiac scenario trauma, to diagnose pulmonary embolism and to differentiate between pulmonary edema and COPD. Lung ultrasound has played a significant role. And when you look at the different common respiratory pathologies, that is pleural effusion, alveolar consolidation, interstitial syndrome, or in the more clinical terms, pulmonary edema, pneumothorax, complete or occult, a lung ultrasound, when compared with the standard, that is the CT scan chest, it's shown a very good sensitivity and specificity. So we can understand that this is a very, very important skill for an intensivist to acquire and to use it in our daily practice to cut down the usage of CT scan and X-ray. And now, even presently, we have international guidelines to use point-of-care lung ultrasound in our regular practice in critical care. So what we'll do, we'll go through a case of respiratory failure and evaluate what are the scopes of lung ultrasound and how it can improve patient care in our practice. So it's a 60-year-old lady, known diabetic, hypertensive, acute lymphoid leukemia, who has received chemotherapy recently, now admitted in the ward with some shortness of breath, and has been managed with supplemental oxygen and antibiotics. During its course, she has developed worsening hypoxemia and eventually shifted to ICU. We received the patient in an impending respiratory arrest scenario, got intubated and ventilated. Initial FiO2 requirement was 0.8. So we did a chest X-ray. It shows bilateral haziness, but because of high oxygen requirement and very little margin of safety, we are not able to do a CT on an immediate basis. Now what? How ultrasound can help in this clinical context? Few basic about the probes that we are going to use. When for surface assessment, that when you're looking at the pleura and the subcutaneous tissue up to the pleura, we usually use linear probe. That's a high frequency probe, better resolution, poor penetration, and we can see up to skin, subcutaneous tissue, pleura, and the immediate subpleural area. When you want to look at the deeper structure like base of the lung or the diaphragm or subdiaphragmatic area, we'll use a curvilinear probe, which has lower frequency, poor resolution, but have a better penetration or deeper penetration. Some basics about the ultrasound. This we utilize in our journey. That ultrasound waves are produced from the piezoelectric crystal whenever there is a current passing through it. Ultrasound passes through one tissue from the probe to the tissue, and at different tissue interfaces reflected back to the probe, received by the piezoelectric crystal, produce the current, and eventually it comes on the screen as a picture. So these four interventions, four principles of light or waves we will use, that is reflection, refraction, transmission, and attenuation. So whenever a transducer is producing a lung ultrasound, it will go to the tissue, and some of them will reflect it back to the transducer from the tissue interface. Whenever ultrasound passes from one tissue to another, from the interface, some ultrasound will be reflected back to the transducer, and it will create an image. Some ultrasound will pass through the tissue and again reflected back from another tissue interface. So this will keep on going on, and eventually ultrasound waves will lose its energy and it will get attenuated. It will become weak. That's why when we are looking at a deeper structure, we have a button in the machine which is called gain, which need to be adjusted to get a better clarity or increase the resolution of this picture. Some of the ultrasound will be refracted back to the other tissue, and they will never come back to the machine or to the probe. Now, as I discussed already, what we do in routine ultrasound, when we're doing ultrasound, we usually suppress the artifacts. That's the standard setting we have. But on the other hand, in lung ultrasound, it is basically the interpretation of artifact. So there are some changes need to be done in the machine to get a clear, better picture. So first we need to have a dedicated lung software, which is called lung preset. Some of the ultrasound machines nowadays have it. We have to turn off compound imaging and harmonic imaging and have to reduce the dynamic gain to get a better clarity. Whenever we are doing a lung ultrasound, we have to report our finding in an objective manner so that another intensivist, another colleague can evaluate the patient for the progress of the disease. For that purpose, we divide the lung into 6 zones, 6 anatomical zones. You can clearly see from the picture. So the 3 vertical lines are the medial line of the sternum, anterior axillary line, and the posterior axillary line. And on the other hand, the horizontal line usually passes to the 4th intercostal space just below the nipple. And by that, we divide this into zone 1, zone 2, zone 3, zone 4, and zone 5, zone 6. So whenever the patient is in ICU and lying down, the most dependent area will be zone 4 and zone 6, not zone 5. So when we are getting an image, the depth that we need to set in the machine is very, very important. So ideal depth when you are setting is around 9 to 11 centimeter anteriorly and 15 centimeter at the base. It also depends on what structure you are targeting to evaluate. If you set too much depth, we may not be able to see the pleura, and we need to place the probe perpendicular. Just like the picture I have shared, because if the probe is out of the plane, it's a non-A, non-B pattern. It doesn't have any clinical significance. If you get a picture like that, we need to modify move our probe to get a more anatomical proper picture. The probe have to be vertical with the skin and the tissue. When you talk about lung ultrasound, we describe it as just like a tip of the iceberg. Why? Even if they're just like an iceberg, a very small part which comes out of the water can be identified. Similarly, in lung ultrasound, doesn't matter how much pathology we have in the lung, it can be diagnosed by ultrasound only if there is a pleural representation. So that means if the lung there's pathology, no pleural representation, ultrasound cannot be able to pick up. But in 95% of the cases, it has shown in clinical context, lung pathology have pleural representation, and ultrasound can be really helpful. So when you are scanning the lung, we have to do both in horizontal and vertical, longitudinal and transverse view. What we have to do is start with the longitudinal view, just as is shown in the picture. We go down from the zone 1, zone 2, zone 3, zone 4, zone 5, zone 6, both sides, so total 12 area. If there is a pathology, in that situation, we have to turn the probe, avoid the rib shadow, have to put my probe in between the two ribs in the intercostal space and evaluate that area in detail to get a more clinically important information. So when you describe lung, there's a part of the lung ultrasound will have a true image and one part will be artifact. So this is the probe area where the probe is placed, and this is the pleural line. So from probe up to the pleural line, there is skin, subcutaneous tissue, muscle, and you can also see the upper edge of the rib and the proximal edge of the rib. right? And here is this shiny structure, hyperechoic structure is the pleura. So up to this, these are true image whenever we are evaluating the lung. From the pleura, because distal to the pleura, this is there and ultrasound cannot passes through it. So all the ultrasound beam will be reflected back from the pleura, giving like to a hyperechoic margin. So beyond pleura, these are artifacts, and lung ultrasound is mostly evaluation of artifacts. So what happens in normal lung? I already discussed skin, subcutaneous tissue, muscle. You reach up to the pleura, that is the surface of the lung. You can see there is a to and fro movement happening at the pleural level because of breathing, and there will be a relative movement between the visceral and the parietal pleura. This indicates that the underlying lung is moving. Whenever we are evaluating lung with an ultrasound, we will get a lot of clinico-radiological information. We are not going to get a diagnosis, a clear diagnosis. We'll get a clinico-radiological information and we have to evaluate it to get a diagnosis. So here we can see that there is a relative movement between the parietal and the visceral pleura, and it indicates that the underlying lung is moving. That's the clinical information we can get. If we can go beyond that, below the pleura, there we can see there are horizontal lines which are parallel to the pleura. We'll see better pictures in the coming slides, which are parallel to the pleura and equidistant from the pleura. Like if this distance is a, then the next horizontal line will be at a distance a centimeter from the pleura, and the next one is again a from the pleura, right? So it indicates normal lung. It's called A pattern. So A lines with lung sliding is called A pattern, which indicates a normal lung. How we can confirm it? We can confirm it with a M mode. So when we are describing a lung, we'll show that. In describing lung, this is the classical picture we say, which is called batwing appearance, where if once we put the ultrasound probe, we can see the hyperechoic pleural line in the center and both sides two shadows, black shadows because of the rib. Ultrasound just like here cannot pass through the bone. So it will create a black shadow like this. You can see the hyperechoic margin of the bone. This is called batwing appearance, just like bat is flying with his wings open. So when you talk about A lines, as you already mentioned, these are horizontal lines equidistant from the pleura, and these are created because of reverberation artifact. It is separated by a regular interval which is equal to the distance from the pleura up to the from the tissue up to the pleura, and it is seen in normal aerated lung. Lung sliding. So I already described it is a to and fro movement between the parietal and visceral pleura that happens during breathing. Once I put a M mode and try to confirm this relative movement, we'll get a picture like this. The skin and subcutaneous tissue, there is no relative movement. So it will come as a horizontal lines. And here, because the lung is moving, you'll get a granular pattern because of the lung movement. So this is called seesaw sign. Just like it is the sand and this is the sea. So it indicates there is a relative movement happening at the parietal pleura and visceral pleura level. But in our case, what happened when you put our ultrasound probe to our patient, we find a picture like this. So how we can describe this? These are hyperechoic lines. Hyperechoic is more white, well-defined laser-like or comet-shaped lines emerges from the pleura, or if there is a consolidation, it will emerge from there also. Here it emerges from the pleura, extend up to the base of the screen. Every point is important. Moving with pleural line or moving with respiration, and it has obliterated A lines. There is no A lines. So if it complies with all these criteria, we describe it as B lines. So what B lines indicate? B line indicates there is deaeration. That means the air which is normally present in the lung has less in amount, and there it is replaced by either fluid or solid tissue. So what happened in case acute situation, mostly this is a kind of pulmonary edema. And because of that, now ultrasound beams can pass through the lung, to the pleura, to the deeper structure. So whenever we get a B lines, it indicates deaeration. In acute situation, it is pulmonary edema. Clinically, what we have to differentiate? We have to differentiate whether it's a cardiac or a non-cardiac cause, because the treatment will be entirely different. So in case of cardiac, again, if I evaluate it pathophysiologically, in case of cardiac, obviously it will be homogeneous. It will involve both the lungs equally. It will show a gravitational distribution because it's a hydrostatic edema. No lung pathology, so the pleural line will be smooth, and there will be no subpleural consolidation. So what is subpleural consolidation? We can see here. So here, when there is a non-cardiogenic pulmonary edema, the non-cardiogenic pulmonary edema, so we can see that the pathological lung, so there is a subpleural consolidation, or we can see the irregular pleural line. It indicates the underlying lung is pathological. In 2012 conscientious evidence recommendation, they have recommended to describe lung into this 4 category when you are doing an ultrasound: normal pattern, multiple space B lines, coalescent B lines, or consolidation, while describing it, the deaeration in a semi-quantitative manner. We also describe it as a alveolar interstitial syndrome. So there can be multiple B lines, 7 mm or more apart, caused by thickening of the interlobar septum. It represents interstitial edema. When the deaeration increases further, the number of B lines increases, and so the distance between 2 B lines comes down. This is 3 mm or less, and it can corroborate with a ground glassing picture in CT and ultrasound. It indicates there is an alveolar edema. With increase in the number and intensity of the B lines, there is a degree of loss of aeration. So just like you can see the CT, with the worsening in the CT finding, gradually, loss with the thickening of the interstitium, gradually the B lines has increased. So in 2012 recommendation, they also mentioned that even in cardiogenic pulmonary edema, we can use lung ultrasound for severity assessment. So increase in the number of B lines indicates that disease severity is higher. Similarly, we can use number of B lines as a response to therapy. Like we give diuretics in a cardiogenic shock, we give BiPAP, the number of B lines decreases, comes down. That indicates patient is responding, and we should continue with that. So lung reaeration can be assessed by demonstrating a change, that is a decrease in the B lines, with our appropriate intervention. Now, day 2, new development, new onset sudden desaturation, apparent worsening in the respiratory function. If I have to go up to 1%, 100%, if I have to 1, what can be done, and how ultrasound can help to evaluate it further? First, we all know that we need to confirm the tube position. We always go by ABC. Can ultrasound help? Yes, I think it has been discussed. Ultrasound can confirm your tube position, whether it's within the trachea or it is outside in the esophagus by a double tube sign. You can see in case of esophageal intubation, you will get a picture like this outside the trachea. If it becomes endobronchial, yes, that can be differentiated with a lung ultrasound and airway ultrasound also, because in case of endobronchial intubation, the tube usually go to the right bronchus and the right lung will be ventilated and the left lung will not get ventilation. So what will happen to the right lung? We'll get normal finding, pleural sliding, a pattern. On the left side, you will get a picture like this. Here, there is a movement happening at the pleural line, surely, but the rate of movement and frequency of movement is much higher compared to the respiratory rate. It is nearly compared to the heart rate that we can see. Okay, because the underlying lung still has air, so you can see air lines. But this is called lung pulse. This is because of the transmission of the cardiac pulsation in the non-ventilated lungs pleura. So the pleural sliding is absent, the lung pulse is present, and because there is air, it is A pattern. We can identify the worsening pulmonary edema in our patients also. So initially, probably the number of B lines is like that. With acute deterioration, we found there's an increased number of B lines with every space between 2 rib, and there can be a confluent B lines like this also. It clearly indicates there is a worsening in the lung pulmonary edema and increase in deaeration. Similarly, with treatment like interventions, diuretics, conservative management, antibiotics, recruitment, there may be a decrease in the B lines also in coming time, which indicate a certain amount of improvement. So for pleural lines, we know the standard, but there are some dilemmas also which we need to be aware. So if someone has a B profile with a regular pleural line, it usually indicates a cardiogenic pulmonary edema. But B lines with irregular pleural lines, we talk about ARDS and subpleural consolidation. But if there is a other mix and match between the finding, like A lines with irregular pleural line, we don't know what is the clinical interpretation. Next, what can happen? Patient can develop a pneumothorax. This patient is on ventilator, probably with a high PEEP. What are the findings? We do an ultrasound. Pathophysiologically, what happened? There is a separation between the parietal and the visceral pleura in this case. So, lung sliding will be absent. will show what is stratosphere sign or M mode. Because there is no air, so cardiac pulsation cannot transmit up to the pleura. So lung pulse that we have discussed will be absent. No B lines, obviously. A line will be present because there is air. And in some patient, we can find lung point. So what is lung point? It is a point where the parietal and the visceral pleura get separated. Now, if I put a M mode where when there is no lung sliding happening, no movement, what we will found that the underlying lung below the pleura is also not moving. So this is called stratosphere sign. So here you can see there are horizontal lines happening and there are no lung sliding present. It will get a picture like this, stratosphere sign. And here the lung is normally sliding. So there is a point where the parietal and the visceral pleura has got separated. This is called lung point. This is pretty specific for pneumothorax. So 2012 conscientious guideline, there's a strong recommendation to describe pneumothorax as presence of lung point, absence of lung sliding, absence of B lines, and absence of lung pulse. Lung ultrasound is more accurately rule out diagnosis of pneumothorax than changing to posterior chest X-ray. It is, as I've already shown, it is pretty sensitive and comparable with CT scan if it done properly. But obviously there are some drawbacks, some false positive and false negatives. Like false positive finding can be present because of poor setting of the depth. Other causes when the lung sliding is not very obvious, like a very bad COPD or emphysema over a lung bulla, if the patient is apneic, post-pleurodesis, when there is a very high PEEP and there is very relative movement, in case of endobronchial intubation, and sometimes in a morbidly obese patient. And sometimes if you falsely scan over a rib, you may also find there is absence of lung sliding. On the other hand, in case of false negative, in case of trap pneumothorax, if you fail to follow the path of the lung pulse and how the pneumothorax has progressed, or it also same time it fails to, sometimes the severity or the extent of ultrasound pneumothorax can be missed with an ultrasound unless we follow the path in a proper manner. It can be challenging. Next, along with pneumothorax, patient can develop a subcutaneous emphysema. You can diagnose it clinically, but if there is associated tracheal lesion, which is more applicable in trauma, not in these patients, then again the air will come into the subcutaneous place. And it will generate something which is called E lines. Just please excuse me for 1 second. Sir, I'm in a meeting, I'll call back. Sorry for the interruption. So in E lines, so these are happens in subcutaneous emphysema, as I mentioned. There are vertical laser-like lines. These are vertical laser-like lines. It start at different level. You can see it has some started from here, some started from here, not on from the pleura. It is the skin. Pleura will be somewhere here, which cannot be identified, and it doesn't reach up to the base. It started from different levels. So by this is different from B lines. And as I already discussed, once there's an air, you cannot see the deeper structure. Because there is air in the subcutaneous tissue, we cannot identify the pleura and other deeper structure. There is another pattern of line which is called Z line, which started from the pleura but does not reach up to the base. Okay, it doesn't have some clinical significance, sometimes mimic pulmonary edema, but we need to be very cautious. All the findings of a B lines need to be complied to diagnose it as a B line. Z line starts from the pleura and does not end up to the base, and it also does not obliterate A lines. See here, there are some vertical lines. You can also see the A lines. These are not true B lines. These are called Z lines without any clinical significance till date. Next, what can happen? We can identify pleural effusion because water fluids is a very good conductor for ultrasound. So we put the ultrasound probe at the base. You can easily identify it. Fluid will appear as a hypoechoic or hyperechoic depending on the content. If it is more hemorrhagic, if there's a high fibrin content, it will appear hyperechoic, otherwise hypoechoic. You can easily identify the collapsed lung between the compression. And if you put an M mode, you'll get a picture like this, which is called sinusoidal sign. This movement happens because of the movement of the lung. That lung is coming to the diaphragm, to the probe, and below, away from it with each breathing. We can identify atelectasis also. A lot of time it is compression atelectasis, where you can see the fluid around it, and you can see a collapsed lung. Within the lung, there are some small hyperechoic streaks we can identify like this. These are the trapped air. We can identify like this is static air bronchogram. Here we can identify the diaphragm and the subdiaphragmatic lever. Sometimes, as we already discussed, in case of pneumothorax, we're not going to get a B lines. But if in case of hydropneumothorax, there is a certain area we can get a B lines where there is a change in the interface. These are the challenges. These are vertical reverberation artifacts which can mimic B lines. We need to be very cautious while interpreting them. Consolidations, yes, we can identify it, and sometimes it can be more helpful compared to CT because CT is a static image. Here you can see that with every breathing, there is a dynamic air bronchogram happening. That is the air coming in into the lung and going out in a solid tissue. So that indicate a consolidation or pneumonia. In case of during the development of pneumonia, you may get a picture when there is some pneumonic effusion. There is a solid part of the lung which acts as like a tissue, followed by there is a gradually increasing duration, a change in duration towards the lung, right? So this is called Schett sign. This is again a clinical radiological finding of pneumonia. How we can use our ultrasound to assess the recruitability and recruitability of a collapsed lung? We can increase the PEEP. We can see whether there is an improvement in the lung volume happening or not. That is deaeration. We can do the drainage of the fluid and see whether the lung is expanding in terms of deaeration. But the challenge will be we cannot diagnose hyperinflation with an ultrasound. That will be the challenge. Now this deaeration part has been evaluated and has been put in an objective manner in different scoring system. This is called deaeration index. But depending on the number of B lines present, whether it's confluent B lines, multiple 4, 5 B lines, 3 B lines, it has been scored, and we can monitor the lung function or resolution of a pneumonia or ARDS in a much more objective manner. Ultrasound has been used for lung recruitment, but as I already mentioned, hyperinflation cannot be identified. That's a challenge. Now for pulmonary embolism, sometimes in conferences, workshops, we ask the fellows to describe, to attendees to describe it, how we can evaluate pulmonary embolism. But we need to remember it's a vascular pathology. The normal lungs should be normal. So you get a pattern, A profile, lung sliding should be present. So whenever you get a normal lung ultrasound finding with severe hypoxia, think of vascular pathology. Pulmonary embolism, probably echocardiography will help. I'll going fast. What are the things you can see? You can see RV dysfunction, dilated RARV, flattening of the interventricular septum, and we can describe the severity depending on the ratio of the right ventricular and left ventricular diameter. If it is more than 1, then definitely it is severe. We can look at the TAPSE, that is the movement of the annulus of the tricuspid valve, and less than 1.6 or 1.5 is significant. We can look for the tricuspid regurgitation and make the pulmonary artery pressure. Parallelly, we can evaluate the lower limb to diagnose thrombus. You can see there is a definite thrombus present here, and the vein is non-compressible. So whenever doing a lung ultrasound, there is a structured protocol developed by Daniel Lichtenstein, which is called Blue Protocol, published in 2008, where with this intervention that we have already described, we can diagnose pulmonary edema, pulmonary embolism, pneumonia, pneumothorax, acute exacerbation of COPD, or asthma in case of in the context of an acute respiratory failure. This is a must-read article for all intensivists. How good is this Blue Protocol? It shows 90% diagnostic accuracy when looking at the ultrasound image. Combination of this with history, and investigations, it can go 100%.
Sir. Okay, can you move?
Thank you.
Should I continue?
Yes.
Can you please?
Akhil, can you please mute?
And sensitivity of each disease is nearly 90% or more, except in PE. And that has been discussed by my previous speaker already, that a small PE can be missed in ultrasound evaluation, but a clinically significant PE, that is which is causing a hypotension, hemodynamic instability, is very unlikely to be missed. And even recent recommendations for thrombolysis has been given on the basis of ultrasound assessment. Come back to our patients. Now, by day 9, patient is clinically better. We are trying to weaning process. Pressure support mode is on, 12/80, 8 centimeter of water, but still he is drawing a tidal volume around 250 ml, which is around 4 ml per kg, 3 ml per kg. She is tachypneic with a respiratory of 35. Now what? Can ultrasound contribute something more? Yes, presently there is a lot of scope to use ultrasound for failed weaning trial to evaluate the diaphragmatic status. What we can do look at for the diaphragmatic movement, what is the diaphragmatic excursion, and also the diaphragmatic thickening with each breathing. And from that, we can identify whether the cause of weaning failure is neuromuscular weakness. Along with that, all the other interventions like deaeration of the lung, non-resolving pneumonia, pulmonary edema, all those things should be reevaluated during this context of weaning failure. So we extubate our patients eventually after optimizing all this, but patient style develops tighter. Can it be predicted with an ultrasound? Yes, it can be done. We do clinically on when patients who are on ventilator, we do for leak test. At the same time, here we can measure the diaphragm, the air column, test the thickness of the air column around the tube before with the inflated cuff and with the deflated cuff. And if we found the distance is less, that the air column is collapsing or the trachea is collapsing on the tube, then we're not going to get any visible measurable air column. Like here we can see some air column. So in that situation, this is the air column here. In that situation, probably we can anticipate that there's a tracheomalacia and probably this patient need tracheostomy. And it has been evaluated extensively specifically for identifying the size of the tube, specifically in children, where the subglottic diameter is the narrowest part, and we need to put a more appropriate size of tube for optimal therapy. Yes, it can be used ultrasound for other airway procedures, which is important part of weaning trial, like tracheostomy, and sometimes to rescue for precothyrotomy. I'm not going into details of that. So if you look at the use of lung ultrasound, it can be used to rule out endobronchial intubation, pulmonary edema, interstitial lung syndrome, to diagnose pneumonia, pleural effusion, atelectasis, pneumothorax, pulmonary embolism, help us to do a thoracocentesis, and sometimes also to take some biopsy from the pleural lesions. And it has all the advantages of ultrasound that has been discussed by all my speakers, like rapid bedside diagnostic test, minimum complication related to transfer, no radiation exposure, can be repeated, low recurring cost. Compared to the idea, it has a smaller learning curve and it's a reasonably high sensitivity and specificity. So we can see that most of the clinically relevant causes of acute respiratory failure can be identified, can be diagnosed with a lung ultrasound, and it works sensitivity and specificity is nearly 100% when you incorporate the echocardiography and the lower limb venous scan along with it. So this is the probably time from move from auscultation to ultrasonication, at least to incorporate it into our clinical practice as an extension of our clinical assessment. By this, I'd like to conclude my presentation. I'm happy to take questions. Thank you.
Delegates, do you have questions?
Hello. Hello.
Yes, Dr. Pritesh, you want to ask a question?
Yeah,
Please go
yeah.
ahead.
So basically, when we are assessing the IVC of a regular patient, we see it quite beautifully. But in the cases where the patient is an advanced cirrhosis with, say, moderate ascites, how do you assess the IVC?
So I don't think it should cause a problem. At least in case of a patient with an ascites, if you go by standard technique like a subxiphoid, if you're not able to find it, you have to go little laterally, and it should not cause a problem. It causes IVC identification of IVC is problematic whenever there is a surgery, colonic surgery happening in the right upper quadrant. Then it can become problem because the gut is dilated, which moves to that direction and causes a lot of artifact. In that situation, the recommendation is to look the IVC through the transhepatic route. You can go to the mid-axillary line and look at the IVC from the through the liver. But the problem is the diameter, collapsibility. Those things are not standardized. That is the biggest problem.
Okay. So here, can the SVC be used for the volume status identification?
Yes, SVC can be used, but you need a esophageal probe. There are some studies which show you can look at the internal jugular vein also and look at the collapsibility. But those are not very standardized. But there are studies in favor of it, that if you are not able to identify IVC, look for the internal jugular vein and its collapsibility.
Thank you.